Welcome back, everyone. If you're studying for that Path P fees exam, well, this deep dive is absolutely for you. We're cutting straight to the chase today, focusing on the fundamentals, tumor classification, staging, and why certain treatments are chosen. We're pulling out those high-yield facts from the source material.
Exactly. The goal here is to, cut through all the noise. We want to focus on the critical differences and how these concepts connect. It's about understanding the why behind it all for clinical practice.
Okay, perfect. So let's start with the absolute basics, the foundation you definitely need for the exam. Benign versus malignant. What is the core difference in how these growths behave?
Right. It really all comes down to behavior. Think of benign tumors as, well, relatively good neighbors. They're usually well differentiated, meaning they look like the tissue they came from. They also tend to respect boundaries. They're often encapsulated, grow pretty slowly, and crucially, they don't spread. The danger with them is mostly about location.
So they're pressing on something vital, like in the brain or near a major vessel?
Precisely. It's a space problem, not necessarily an invasion problem.
Got it. So then malignant tumors are basically defined by not respecting those boundaries.
Exactly right. Malignant cells are poorly differentiated. That's the term anaplasia you need to know. They sort of lose their job description, become disorganized, and frankly, aggressive. They're invasive, they grow fast, and the defining characteristic, the really scary part, is their ability to metastasize. They can travel through the blood or the lymph system.
And finding that invasion or seeing spread to the lymph nodes, that's the key signal we're dealing with, true cancer.
That's the critical flag. Local invasion and lymph node involvement are hallmarks of malignancy.
Okay, that makes sense. And that potential to invade leads us right into, well, how this shows up clinically. When a cancer develops or comes back, the signs seem to fall into pretty clear categories. Locally, you might feel a lump, maybe see skin changes like dimpling or have nipple discharge. But then there are those systemic effects. They tell you the body's really fighting something serious.
Oh, absolutely. Those systemic effects can be quite devastating. You see things like profound fatigue, maybe anemia, or that severe metabolic wasting called cachexia. Cachexia really shows how the cancer is hijacking the body's energy. And on top of that, there's often immunosuppression, which leads to those persistent frequent infections.
Then the metastatic signs, they're like a roadmap, right? Telling you where the invasion has actually gone.
Exactly. Bone pain could mean it's spread to the bones, shortness of breath, a cough that won't quit that points towards the lungs. Neurological symptoms might signal brain mets.
So tracking the spread is obviously crucial. Beyond just a biopsy, what else is involved in diagnosis and really understanding the stage?
Well, we use advanced imaging, of course. MRI, CT scans, PDT scans are common, and lab tests looking for tumor markers like CA 15-3 in breast cancer, for instance. But critically for staging, and you really need to grasp this, are two things. The sentinel node biopsy to check those first draining lymph nodes, and then the histology, specifically identifying the hormone receptor status. Are the cells positive for estrogen receptor, ER, progesterone receptor, PR, or the HER2 receptor? That's vital.
Right, and that information directly influences treatment.
Yeah.
Which brings me to axillary lymph node removal. It seems like a major procedure carries risks like lymphedema. Why is it so important?
That's a really key clinical point, that balance of risk and benefit. We do it because staging is absolutely paramount. Knowing the extent of spread through those axillary nodes is probably the single most critical factor for figuring out prognosis and planning the entire treatment strategy.
So it guides everything that comes next.
It really does. Though medicine is always trying to refine this, using techniques like the sentinel node biopsy to avoid full clearance if possible, if that first node is clear, but determining spread is non-negotiable.
Okay, so with staging as our guide, let's quickly compare the main treatments. What are the goals and the trade-offs for chemo versus radiation versus hormone therapy?
Great question. You need to think systemic versus local. Chemotherapy is your systemic approach. It's like sending out troops throughout the whole body. It targets cancer cells that might be circulating or tiny micrometastases you can't even see. This really helps cut down the risk of the cancer coming back later.
But the downside is it hits healthy cells too, right? Hence the side effects.
Exactly. That's the trade-off. Nausea, hair loss, fatigue, and that significant immunosuppression because it affects bone marrow.
Okay, so chemo is systemic. What about radiation?
Radiation is the targeted local cleanup crew. It uses high-energy rays focused right on the original tumor area or maybe lymph nodes involved. The goal is to kill any residual cancer cells left behind after surgery, for example. It's very effective locally.
But the side effects are local too.
Generally, yes. Skin irritation, redness, sometimes blistering in the treatment field, and potentially long-term scarring or tissue changes in that specific area.
All right. And finally, hormone therapy. This one's more specific, isn't it? Tied to those receptors you mentioned.
Absolutely. Hormone therapy is only relevant if the tumor cells have those estrogen or progesterone receptors, ER positive or PR positive cancers. If they do, it tells us that estrogen is basically acting like fuel for the tumor's growth. So therapies like tamoxifen, which blocks estrogen receptors, or drugs that lower estrogen levels, or even removing the ovaries,
Ulceration.
right, oophorectomy, they all aim to cut off that fuel supply. It's a very targeted strategy based on the tumor's specific biology.
Makes sense. But it comes with its own set of trade-offs.
It does. Because you're messing with hormones, the side effects often mimic menopause, hot flashes, vaginal dryness, and there could be other risks too, like blood clots or effects on bone density, sometimes cardiovascular concerns depending on the specific drug.
Wow. Okay, that was a really efficient run-through. So key takeaways for the exam seem to be: nail the difference between benign and malignant behavior, understand that staging really hinges on lymph node involvement,
Mm-hmm.
and know the core rationale: systemic versus local, targeted versus broad for chemo, radiation, and hormone therapy, including their main trade-offs.
Absolutely. And, just as a final thought to mull over, think about how critical identifying those specific markers, ER, PR, HER2, has become. It really highlights how personalized cancer treatment is now. We're moving away from just treating cancer and towards treating a very specific molecular subtype of cancer. Maybe dig a little deeper into how those receptor blockers actually work at the cellular level. It really drives home the connection between basic pathophysiology and clinical treatment.